Okay, thank you for submitting your case. Today's case was submitted from a recent attendee of one of our classes, our workshops, our hands-on workshops, and one of the nice things that we like to provide for our attendees is the ability to walk them through the first several cases to make sure that they're doing everything the way that we teach, and to make sure that they're comfortable with it. We find that it helps people move forward and helps them move farther along in their implant journey. So in this particular case, the first thing I always ask is when we look at this, we're missing tooth number 5. My first question I'll ask myself or to the attendees is what type of surgical guide we're going to use. And this is an opti guide through and through. There's very little metal artifact. We've got plenty of natural teeth to work with. To provide an opti guide, we need essentially three things. So one, cone beam scan, which we have here. Two, CEREC data that's integrated in. And three, an implant plan itself. So here, this doctor has went ahead and put our CEREC data in, and we can take a close look here. And one of the things I do like to check is to make sure that it's well integrated. And here we can see that the data is quite well integrated. So we have all the makings of a great Opti guide. So now let's go ahead and take a look at the actual plan itself. Here he has planned a Nobel Replace Select tapered implant. This particular implant is the preferred implant of this of the dentist and or the surgeon that may be placing it. So here we are. So we'll go ahead and take a look at our evaluation. So step one, mesiodistally. So here what I see is I can't see the roots. So the reason we can't see the roots again is our cross section right here. Here in the axial view, our cross section is not through the teeth. So we'll use a 360 liner here. And now we can see that our orange line cross-sects the teeth, and we can also see the adjacent roots. So mesiodistally, we look pretty darn good there. One thing I would like to do is go ahead and change this to a different size implant so we actually see the implant body itself. Because unfortunately with the Nobel we do not have the 3.5 by 11.5 implant. We have the 3.5 by 10 by 13. So just from a viewing perspective, I'll do that. Buccolingually, what I look at here is we look pretty good. If I were to be critical, what I would look at here is say that we have a lot more room here than we have here. So why take that risk? Let's go ahead in this case. Let's go ahead and move our implant and or tilt our implant so we have a lot more space available. Now it looks a little bit more centered buccolingually. Bone level looks very good here. Here we're at the level of the bone. That should be pretty straightforward here. The only thing I would take into consideration, I don't know the history of this tooth, but I would take into consideration the emergence profile. In other words, are we going to have enough room from the head of the implant to emerge out? And it's cutting it close, but it's possible there. So if anything, I would say maybe I would actually place this implant a hair deeper to go ahead and allow a little bit more emergence profile like that. So room for developing the ideal emergence. Next, we'll look at vital structures. In this case, the vital structures will be adjacent teeth, the buccal plate, and the sinus. And we are totally good in all those directions. In fact, we're able to get a 13 millimeter implant in there. Next, we will look at the occlusal table. And again, I made a change here. So let me go back to the original plan so we can compare. And your occlusal table in the original plan looks pretty darn good. If anything, I would say that in looking at it right here, we can see that we're a little buckled to the central groove. So if anything, I would probably move this just like so. But again, you look good. But let me go back to the plan that I put together since I had moved the implant a little bit to the lingual to get us more space in the buccal plate there. Here we can see as we go to our occlusal view in the axial, we can see that we're definitely a little bit buccal. So what I would choose to do here is our choices are what to get this into the central groove. One, I can bodily move it, not such a great idea necessarily, or we can tilt it. So in this particular case, I wouldn't necessarily tilt all like that. I'd probably tilt a little bit there and a little bit there and maybe just a little bit more. And now we can get this implant more in line with a central groove. our occlusal plane. So let me go back to our original plan here, and let's take a look at our occlusal plane. So if I were to critique this, what I would say is our occlusal plane is looking a little bit slanted there. So if anything, what I would do is tilt this implant like so to get that slant a little bit less and more in line with the normal curve of SPIE. So now let's go back to the plan that I made. And again, let's make it so we can see the adjacent teeth. And same thing here. Let's go ahead and tilt this. And as I tilt it now, we're more to the distal. So I will need to take this back to the mesial just a little bit there. Okay. Now, once we have all of these things set and happy, the next thing that we will take a look at is our sleeve. Our sleeve is in position. The only thing I would say about a sleeve here is not a fully guided sleeve. We have used the CCAP pilot sleeve. So let's go ahead and change this out to the Nobel Guide sleeve and get that in there correctly. And now we can see better using this sleeve where we are in relationship to the adjacent teeth. So here we can see in the axial view that we have less space on the distal than we do on the mesial. So in this particular case, what I would do is I would go ahead and tilt or move the implant more, just like so. Okay, and that should take care of that. And then we'll go through our 360 and everything looks really, really good there. We've got just enough room between the adjacent tooth, the canine, and that. So I think we're good. The only thing that I would now consider in this particular case is in a premolar, my preference is to go to a 4.3 millimeter implant. Based on some of the changes that we did make, we have more than enough room to go to a 4.3 by 13 or even a 4.3 by 11.5 or 10 would be more than adequate here. So I would probably choose for the 11.5 in this particular case, but a 13 can also work here. So everything's ready to go. The plan, the original plan was not very far off at all. Very well done. The only thing I would say is I would be a little hesitant about, even though we have enough space here, is that we have definitely a lot of room here on the palatal. So I would go ahead and tilt that implant away and then move it to get me more space. I'm just a little bit more hesitant to try to put the implants too close to the buccal plate. Thank you, and I appreciate you sending in the video.